Thanks, Tom. Can they see me there? Okay.
Yes, they can.
Okay, perfect. So, yeah, I feel a little intimidated being surrounded by all these smoking cessation experts. I am not an expert at this, and I put together what I think is a little bit of an unusual presentation for you. If anything, I'm number 4 out of 5 presentations. This might give you a little comical break because I'm going to kind of take a different direction here. All right, so what I'm going to do in the next 20 minutes or so is give you 5 little mini vignettes of 2 or 3 minutes each. I'm going to tell you what I love about primary care, tell you what I hate about primary care, which I'll try to hold down to just 2 minutes. I could probably do 8 hours on that. I'm going to tell you what I love about the New York State quit line, and I'll tell you what I hate about the New York State quit line, and that'll be a pretty short slide because there's very little that I don't like about the quit line. I'm going to talk a little bit about automation and how we could be using that better in healthcare. And then I'll wrap up and talk about the Rochester Regional Journey as we implemented the OptiQuit program there. So this is what I love most about primary care. When I was growing up in the 60s, there was a show, Marcus Welby MD. I was about 9 years old watching this, and he was the model of the perfect primary care provider. He was a jack of all trades and a master of none. He knew a little bit about OB and a little bit about surgery and labs, just enough to get by. I had this hotshot whippersnapper new partner that was young. He'd ride in on a motorcycle every day, had all these crazy ideas. But Marcus Welby, he built relationships with his patients. He knew them all on a first name basis. He knew their kids. He went to their weddings. He went to their funerals. He made house calls. And you know, he didn't prescribe a lot of medicines. What he did was develop relationships with patients and help them lead healthier lives through those relationships. And I think there's remnants of Marcus Welby in primary care now. I think any primary care provider in their 50s probably subconsciously went into this profession by watching Marcus Welby do what he did back in the 60s. And I got to tell you, early, you know, I actually secretly wanted to be his sidekick and ride the motorcycle. And I think I actually did early in my career. I wanted to change the world and do all these newfangled things. But, you know, after 30 years of being in primary care, my favorite part of the day right now is just being in the room talking to a patient. And it's even better if I'm not talking about medicine, if I'm talking about their life and their family. And these are great opportunities to help a person change by being a trusted partner with them. So I don't particularly hate these agencies, and I understand why we need them. But you know, what's happened in primary care is we have all these external agencies kind of putting their fingers into the pie. I read once, and don't quote me on this, I'm not sure if it's entirely true or not, but I read once that there's 160 decision points that have to be made when you're in that room for a 20-minute visit, coming from multiple agencies. I also read once that in a typical 8-hour day in primary care, there's about 16 hours of metrics that need to be taken care of after you see the patients. So it's you know, and Lean Sigma experts call this analysis paralysis. You get to the point where there's just so many things asked of you in a typical day that you shut down and you start to prioritize. And the older primary care providers say, you know, let me just have a conversation with the patient. The younger ones struggle. They want to get everything done because they're being told they have to do all these things, but you can't. It's impossible to meet every single metric. Smoking cessation is one of them, and the smoking cessation folks will tell you how important that is, but the hypertensive folks will tell you how important it is to talk about diet and salt control. The diabetes people will tell you how important it is to talk about their foot care and their last eye exam. And the colonoscopy people have their concerns, and the immunization people have their concerns. And just, you get to the point where you just can't do everything in the primary care practice. And I think that's kind of frozen us in trying to get everything done And this is kind of the reality of a primary care provider right now. So what I love most about the New York State Quit Line is it's clearly a convenient, high quality, evidence-based referral source for us primary care providers. It's a silent partner. They're someone that you can kind of offload this work to them and let them develop the relationship with the patient around one thing, around smoking cessation. It's a box we can check off without actually having to do it ourselves. And it's a wonderful resource that we have in the state that we should all be using as primary care providers. So I don't know how up to date this form is, but what I hate, well, first of all, what I hate most about the Quit Line is that the patient actually has to reach out to the Quit Line for it to work. And so you tell a patient, here's the number, here's the website, I think it's really important you reach out to the Quit Line. If they don't do it, then it's wasted effort. The Quit Line themselves will say that it's better to have the Quit Line reach out to them because the success rate is 100% because this is what the Quit Line does. The problem with that is you have to give all this information to the Quit Line. And here's an example on this form of this fax to quit form. And again, it becomes one additional thing that you need to do in a busy day to go find the form, fill it out. I know it's only 30 seconds to fill this thing out, but you have this long list of all these 30-second activities that you need to do during the day. So a little bit about automation, and this picture is the door of a lavatory on an airplane. It's a perfect example of how you can utilize the power of automation. You see that little latch there. If you pull it to the right, it not only locks the door, but it turns the light on. So you have to pull the latch unless you're going to sit in this room in the dark. And it also takes the vacant sign on the outside and moves it to occupied. So one simple step creates 3 activities: turns the light on, locks the door, changes the sign outside. And you see on the top there, there's not this whole set of instructions on what you're supposed to do and what's going to happen when you do it. It's quite intuitive that when you walk into that bathroom, you switch the switch over to the right. So we need more switches like this in healthcare because in order to offload all of this work being put on us by all these agencies, we need something simple where you can just click a button and a series of activities occurs automatically. If we could get to that point, we could meet more of these metrics and actually have more time to sit in a room and actually talk to the patient. There's the nirvana of automation is to have the patient do it for you, or currently we're having the nurse do it for us in many cases. There's a pilot project out of the Mayo Clinic where the patients get into their portal before the visit and check off all those boxes for you. So they check off their smoking status, they check off their depression status, they reconcile their medicines, and then when they arrive for the visit, the nurse drops the vital signs in, and then they go see the provider. And so it's a very interesting concept that let the patient themselves click these buttons, and then it leads to a series of events. It schedules their eye exam for them. It gets them to the Quit Line. So we have a long ways to go on this, but I think automation is gonna be the key to having more and more referrals to the Quit Line. So a little bit about our journey on the OptQuit program, and you see on this slide up in the right-hand corner, this is actually when it started, I think, April 10th, 2015. We kind of, as a community, started having a conversation about automating the referrals to the New York State Quit Line. And we started having these conversations at Rochester Regional. And after we were able to convince our leadership that this is the direction we should go in, the first thing we did was we printed out this schematic of what happens currently when a nurse is talking to a patient about their smoking status. And you can see on there that the screening starts, and if the patient refuses to be screened, everything stops. If the patient says they've never used tobacco before in their life, the screening stops. If cognitively the patient is unable to answer a question, the screening stops. But if they get to the point where the nurse clicks either current or previous tobacco use, then a series of questions pops up there. How long they've been using it? Are you ready to quit? There's a half dozen questions on there, both for smoking and for smokeless tobacco. So you can see on the bottom a little scribbling there is that those are my arrows saying at this point we need to put a button in there where the nurse can click refer to quit line, and the arrows go down to the bottom where it says refer to quit line. Patient doesn't want to be referred, the whole process stops. The patient wants to be referred, then it drops into some IT code of how does that information get to the quit line. So the true OptQuit program is actually designed to have that button suppressed. So the script that the nurse would use would be something like, we're really concerned about your smoking status. We'd really like to have you talk to the New York State quit line. If you tell me no, I'll unclick this button, but otherwise your information is going to the quit line. So our legal folks weren't happy with this phrasing, and they told us we needed to do an opt-in, which means the nurse has to say, if you want, I'll click this button, and then your information will go to the quit line. I'm working on some other projects right now that are similar to this, and the opt-out model is hands down the best model. I'm going around talking to a lot of doctors right now about a separate project, and they tell me over and over again, don't give me another button to click. But we did the opt-in for this because that's what we were told we were going to do. Perhaps now that we've eased into this over a few years, we might look at going back to the opt-out. So once we got to this point and leadership had decided this is what we should do, and we kind of decided where we should put that button, then it was time to hand all this off to our IT folks. And the New York State quit line actually has a manual. I think it's about 35 pages of computer code. I couldn't make it past the first paragraph. But what I did was went down to our IT department and said, here's the manual on how you hardwire this, how you do the computer coding. And so the geeks can talk to the geeks and they can figure this out. Unfortunately, our IT folks had a whole lot of projects in the queue. And this sat there for quite some time. I think it's about 5 or 6 months until they actually got to this project. The cynical side of me says it probably took just a few hours to write this code after them sitting on it for 6 months, but it took about 6 months. And then I got an email one day and they said the button's there. Kind of the problem with that, I'm going to go into a little circle of trust here and air a little bit of dirty laundry. While I was waiting for the 6 months to occur, I moved on to other projects, and I had several projects under my belt at the time. And my master plan was, once the button appeared in Epic, to go do some educational nursing staff and say, hey, look, now you got this button here. Here's the importance of clicking it. Here's the conversations you have with patients. This is what's going to happen when you click it. But it didn't occur. I had too much on my plate. Our nursing education department was going through a transition. Their leader had left. And we were about a year into a merger that was taking up everybody's time. So in reality, what happened was the button just appeared. And you know, nurses that were doing tobacco screening saw a new button. And this wasn't done purposely, but it was very interesting to see what would happen without saying anything if a new button occurred. So I'm going to break down this slide a little bit and show you what occurred. And if you look at the left side of this slide and the 6 month wait up period, waiting to get this button to occur, you can see there were no referrals to the quit line at all. What's very interesting is once the button occurred, we went from 0 to about 100 referrals a month to the quit line. And this is without telling anybody what to do, without any education at all. And I now a year later, I wonder what the referral rate would be if we actually talked about this button rather than just having it appear. Another interesting thing about this slide is this is inpatient only. So there were some barriers to getting this started. The IT team on the inpatient side had some better availability. They had less projects than on the outpatient side. And the leadership structure on the inpatient side, there were less barriers to get this done. So when I was faced with trying to launch this project, I said, let me do inpatient first, because there's less barriers and I can get this thing off the ground, and then I can go back later and we can have a discussion about outpatient. So if you think about it, and I was thinking about this last night, that this only occurs, nurses only see this button probably about 50 to 100 times a day. And that's based on how many patients are being admitted into the hospital. This is part of the process of checking a person in as they get admitted and asking some basic questions. So 50 to 100 times a day a nurse is seeing this button, and it's resulting in about 100 referrals a month to the quit line. I have submitted the request to have this appear on the outpatient side, but it's been sitting in the same queue that it was in on the inpatient side. But I'm actually scheduled in the next couple of weeks to go have this same presentation and this same discussion about this slide with the outpatient leadership. Because if you imagine on the outpatient side, just a guesstimate is probably 3,000 to 5,000 times a day, a nurse is going to see this button. And if you can see the results here of what happened when this button was appearing, 50 or 60 times a day, imagine how many quit line referrals, automated quit line referrals, are going to occur when this button is appearing 3,000 to 5,000 times a day. So, we got some initial evidence that this is working really, really well. We have some exciting things on the horizon in terms of seeing this grow once we move it over to the outpatient side. And I think I'll stop here. I don't know what I'm doing on time, but I think I'll stop and let you guys ask some questions. And then I'm going to turn it over to Scott, who's going to talk about the URMC journey towards OptiQuit. And I'm sure he'll have a lot more technical slides than I